Good morning. I managed to catch a nasty cold yesterday, and I was telling Jane this morning, if I fall over while I'm up here talking, don't call 911. Just give me a soft place to land. I've fallen asleep from the drugs. I've been in healthcare since '76, and I've never seen a situation like we have today. There's more uncertainty in what's going to happen at the state level, the federal level, private insurance, the physician market. Everything is in flux. And when we did our budget projections for next year, we had one scenario that said we're going to have a wildly successful year financially, and we had another one that said it's going to be a disaster. And the assumptions between the two, the difference in the assumptions isn't that great. So it's an incredibly unpredictable environment in healthcare today. And I'll give you the punchline before I get into the presentation. Basically, I was here 3 years ago and told this group that healthcare was badly broken and a lot of the indicators were going the wrong way and how difficult it was going to be in the future for our country and for healthcare. And unfortunately, I can stand here today and say I told you so. It has come to pass, and I think at that time, the general public wasn't very focused on healthcare, and now you can't pick up a newspaper or read an electronic article someplace. Any place you go, all you hear is about healthcare. So the bad news is the next few years and the future for those of us who are in the healthcare business is going to be very difficult. It's going to change dramatically. The reimbursement is going to change, and we're going to be severely challenged to take care of our communities. The good news, in a nutshell, is that our community continues to grow. And as our population ages, we use more and more health care. And there's going to be a lot more health care delivered in this community in the future than there is today. So those of you that are in health care are going to struggle mightily to make ends meet and to make everything work the way we want to take care of our community. Those of you who are not in health care are going to continue to see large expenditures by the health care sector. So that's my presentation in 1 minute. National trends, the population nationally is aging like it is locally. Our national debt's in big trouble. Healthcare reform is going to happen. I would like to say that the administration's plan is really to reform insurance and how it's provided, not to reform healthcare. Their plan doesn't reform how doctors provide care or hospitals or anybody else. It just changes how it gets paid for and realigns some incentives, but not nearly enough. What we have to do is we have to develop a system as a country where healthcare providers are rewarded for keeping you healthy rather than curing you after you become ill. And our country does incremental change. It doesn't do one big fell swoop change. And I fail to see how we're going to go incrementally from where we're at to where we need to go without an awful lot of pain. The other drivers, there's a huge amount of uninsured every year, and it's more each year as health plans increase deductibles and as companies drop their insurance. And there's also a huge increase in charity care. And we've really felt it at Kadlec. I have a chart later I'll show you. This is simply a quote. I'll let you read it, but it basically says there's going to be a lot more elderly in the future relative to the rest of the nation. And that means that those of us who are retiring and have health care issues are going to be a burden for our kids and grandkids. The reason it's going to be so difficult, and I don't know if you can read the numbers from back there, but this is millions of people in the United States with chronic health care conditions. In 1995, there were 120 million, and by 2030 it's projected to be 171 million. These are cardiac conditions, congestive heart failure, diabetes, the diseases of the elderly that are very difficult to avoid. And as the population ages, it's not a linear progression of more health care. It takes off like this as you get older, and it costs more to take care of the elderly. As a percent of our gross domestic product, we're approaching 20% in a few years. We're at just a hair under 18% this year. Back in '85, it was down below 11%, a little over 10%. So that's what the trend looks like as a percentage. This chart shows what's going to happen. The red line is tax revenue for the federal government, total tax revenue, total annual revenue. And the three blue shades. The bottom one is Medicare spending, and you see how it increases dramatically. It's the biggest increase. That's what's being driven by the aging of the population and those chronic illnesses. The middle one is Medicaid, and that goes up primarily because the new plan proposed by President Obama and that kicks in 2014 provides Medicaid to a lot of people who today don't have insurance, so Medicaid's going to jump way up. And the top blue section is Social Security. And basically what this is telling us is by 2050, 100% of the federal budget will be spent on Social Security and health care. Now, obviously, that's not going to happen. Something has to give. Something is going to give. We're either going to be bankrupt or we're going to change how we do health care. The question is, how long is it going to take Washington, D.C. to deal with the crisis? And in my experience, they deal with crises about 10 years after it happens. Insurance coverage in the U.S., roughly half the health insurance today, I think this was 2010, roughly half the health insurance is provided by employers. This is particularly important if you understand where employers are going to go with their health insurance plans in the future. I have a slide, I'll address that in a minute. But 16% of our population is uninsured. 17% are covered by Medicaid. From a patient perspective, if you're on Medicaid, it's a pretty good plan for putting nothing into it, or virtually nothing. If you're a healthcare provider, Medicaid is not too much better than uninsured. It pays pennies on the dollar, and most healthcare providers lose money on both Medicare and Medicaid today, and that's kind of scary. This is the number of uninsured Americans who are under 65 through 2010, and you can see that number continues to grow every year. Kadlec charity care. Charity care and bad debt are two distinct things. Bad debt is when somebody incurs a health care bill and they have the ability to pay it and they don't, or they choose not to. Now, I will grant you some of those folks fall into that gray area where they're not really indigent or poor, but they don't have enough income to be able to pay the co-insurance and deductibles. But bad debt is those that have some ability or the ability to pay and don't. Charity is people who genuinely can't pay their bill. The hospitals in the state of Washington several years ago agreed upon a standard definition for charity care. And I can't quote you the specifics off the top of my head, but it basically says if you're at the poverty level, that's charity care. And if you have X number of dependents, then the level gets higher and so forth. And most hospitals today have a sliding scale that if you meet charity, we write off your bill. If you come in the hospital and you say, I can't pay my bill, I can qualify for charity, we do an analysis of your income. And if we determine up front that you really are eligible for charity care, you never get the first bill. We write it off immediately. A lot of times we find out after the fact, after they come in and say, I can't pay this. But our charity care went from $1.5 million a year in 2000 to $26 million last year. Now, that $26 million is charges. It's not what it costs us to provide the care. It costs us about half that to provide the care. Nobody pays, none of the insurance carriers or Medicare or Medicaid pay charges anymore. It's almost irrelevant what your hospital bill is. Medicare tells us how much they're going to pay us. Medicaid tells us how much they're going to pay us. And we negotiate with Blue Cross and Group Health and others on a contract. And basically, we get about 47 or 48 cents on a dollar right now. For every dollar we charge, we collect about 47 or 48 cents. And our expenses and revenues pretty much match up. So somewhere in the neighborhood of 45 to 50% of that 26 million is what it really cost us to provide that care. So somewhere between 12 and $13 million we actually spent actual cash to provide care with no reimbursement last year. And that doesn't include the ones who couldn't pay their bills. At the rate that line's going up, life's going to get pretty darn difficult for providers. And you know, I know the other two hospitals in the community are experiencing the same thing. They're smaller numbers, but in proportion they're similar. Around the state and around the country, this is what everybody's seeing now. It's not just Kadlec. Some things going on within the state. There's a thing called a critical access hospital. It's a 25-bed hospital, typically rural. that gets special reimbursement from the federal and state governments. Medicaid pays cost. They actually do a formula and they figure out what it costs the hospital to take care of Medicaid patients that year, and they reimburse them at their cost. And they get paid a whole lot more than the other hospitals that are not on that system. So in our community, Lourdes is a critical access hospital, and they get preferential reimbursement for Medicare and Medicaid. At the state level, the governor's budget proposes to eliminate cost reimbursement for critical access hospitals in the state of Washington. There are 38 hospitals that are critical access that provide a huge amount of Medicaid business. If they go from, and I'm not speaking about Lourdes in particular, I'm just talking about critical access hospitals in the state of Washington. If they lose their cost reimbursement, I would predict that many of them will become outpatient facilities and they'll close the hospitals. The inpatient beds will close. That's the real pressure that's happening on hospitals. And that's not a criticism of the state government, because I understand the crunch they're in. But the reality is, I think there's a high probability that if they do that, a lot of hospitals will close. Basic health plan is a state plan for those with low income. It's a kind of a different version of Medicaid. It's been dramatically downsized in the last 2 or 3 years. In the last state budget cycle, and again this time, they are now putting limits on what they will pay for in the emergency room. Basically, it'll take a significant trauma or a significant life-threatening event before the state will pay for a Medicaid visit to a hospital emergency room. I talked about bad debt and charity care. Then the last one, near and dear to my heart, is safety assessment. There was a mechanism worked out with the legislature and the State Hospital Association a couple of years ago, whereby we would work together and they would actually tax the hospitals. Hospitals would voluntarily pay a tax to the state. State would go get a federal match on that money, and then most of it would come back to the hospitals after the administrative fees. Last year, the legislature decided they couldn't afford to do that, so they reneged on the plan, but they continued to tax hospitals. So hospitals are now paying a tax to the state government, and the state is now using that for other things than health care. So, it wasn't bad enough, but the state started taxing us. As an employer or a purchaser of health care, what are people looking for? Or what are you entitled to get? We think it's absolutely necessary to have higher outcomes, better outcomes, and higher quality of care. The cost has to be driven down. We need to coordinate care better. It's incredibly frustrating to bounce around in the healthcare system today, regardless of disease. The physicians, the hospitals, the PT providers, everybody out there, we just don't coordinate what we do. The information flows just are not there. We have a bunch of mom and pop industries that just don't function well together yet. We've got to be more transparent. You as a consumer and the businesses as the purchasers need to be able to go out and someplace find information about quality, about outcomes, and about cost. And you need reliable information, and you have to have a reliable way to measure those things. What do I think is going to happen or should happen? I think you'll see reductions in variation. I think you will see physicians and hospitals forced to standardize how they do things. We're doing much of that at Kadlec, and we have a long ways to go. But I can show you in our intensive care unit, we have far better outcomes than the rest of the world, and our cost is far lower because we standardize how we do things. And all of our physicians, all of our nurses, and all the people that work in that ICU do everything the same way every time for the same diseases. And we have to take that to the rest of the industry. Health insurance exchanges. This will probably be the biggest change for the employers. Around the country, we're seeing states set up insurance exchange programs. A health insurance exchange is basically going to be where, probably run by the government, probably at a state level, and each insurance company is going to have to put in a standard package of benefits. And you're going to be able to go probably on a website, and it's going to say, for this package of benefits for your employees, you can purchase from this company for this much, this one for this much, and so forth. Think of it as eBay for health insurance. And you'll be able to see for a standard package. Now, I think what's going to happen is that standard package is going to be a lot less benefits than what most employers provide today. So you're also going to see probably some co-insurance plans or some supplemental plans. If you're on Medicare, you can buy supplemental to cover what Medicare doesn't cover. I think you're going to see health exchanges where companies buy insurance off of a health exchange, and then they offer to employees, or private insurance company offer to employees, supplemental plans to layer on top of the plan they got through the exchange. As I indicated before, we have to align the incentives of providers. Right now, hospitals are incentivized to do this, doctors are incentivized to do this. We compete to here, we compete there. The incentives are all backwards. We're all paid to make you healthy, but we're not paid to keep you healthy. You're going to see consolidation in physician practices. You're going to see consolidation in all aspects of healthcare, and we're already starting to see a lot of consolidation of hospitals around the country. We have to change how we take care of people at the end of life. Depending on whose numbers you want to believe, there's this incredibly large percentage of healthcare dollars that gets spent in the last 2 or 3 weeks or the last 2 or 3 months of people's lives. We go to extraordinary means and spend huge amounts of money for grandma to be in the ICU when there's no hope for us to do anything for her. The American people just refuse to accept that someday you're going to die. And other societies seem to accept that. And I'm not proposing that we should go around pulling the plug on grandma by any means. But there are better ways to provide end-of-life care than what we do. Sometimes the way the healthcare system deals with end-of-life, I think, is pretty inhumane. And it's outrageously expensive. And if we just figure that out, there'll be enough dollars to fix healthcare. Tort reform. Again, depending on whose numbers you want to listen to, as much as 30 to 40% of the imaging procedures that are done every year are done defensively by physicians who order them. So if they have to prove later that they were correct, they have an image. They don't do it to diagnose the case. They do it so they can document that they were right. Cost shifting, private insurance. You guys as employers are paying for the federal and state programs that don't pay for Medicare and Medicaid. Every time Medicaid pays us 50% of our cost, we're looking to the private insurance market to make that up. That just doesn't make sense and is not sustainable long term, and it keeps us from competing in international markets where employers in other countries don't have to do that. And as I mentioned, we have to manage chronic conditions better. What's it mean here? This is an internal projection we did a couple of years ago. Probably the most important number on that slide is in the lower right-hand corner, where it says that the senior population is going to grow by 40% between 08 and 18. And overall, the population is going to grow by 27% during that time frame. I'll back up real quick. That isn't the Tri-Cities. That's what we consider to be our service area, which includes way down into Oregon and some of the surrounding counties. Reducing costs. We're going to continue to get paid less relative to the services we pay. We're going to have expense pressures to reduce what we spend. We're going to see physician practice consolidate. I think you're going to see in a few years virtually all the doctors in town work for the hospital systems. There'll be a few independent ones, but they're rapidly migrating to the hospital systems. A number of critical access hospitals become outpatients. I think you're going to have to see consolidation someday of the hospitals. You're going to see us eliminate frills. And I don't know how long you're going to have valet parking at Kadlec, but someday it's not going to make sense. Nobody pays for those things. We do them for competitive reasons and we do them for service reasons. Some of the things we do for service reasons we're going to have to question as we move down the road, and all healthcare organizations are doing that. The other thing is you're going to see fewer physicians and more mid-levels. You're going to see nurse practitioners and PAs. You get a cold, you need to go to your doctor. You're not going to go to the doctor, you're going to go down and you're going to see the nurse practitioner. You can train them faster, they make significantly less money, and we as a country can produce them much more quickly. We're way behind the curve on training physicians in this country. Employers can expect that standard package from the health exchanges, insurance exchanges, and the supplemental insurance. We may see some direct contracting where hospital and healthcare systems contract with employers and cut the insurance companies out of the middle. I think there's no question employees are going to end up paying a higher percentage of their health care cost on their insurance premiums. Some of the larger employers are going to end up with clinics right on site. Either they subsidize them or somehow control them or partner with a healthcare system so they can keep people healthier to keep their expenses down. We have to have a lot more transparency. If you haven't looked, Kadlec has endorsed transparency. We have a lot of information on our website about how we do things and how we're doing compared to the rest of the world. And most of it's pretty good, but the bad's out there with the good. And we have to have some more meaningful dialogue between healthcare systems and employers to come up with a better system. Mitigating factors, you know, we've got the lab, we've got Hanford, we've got agriculture. You know, all of those things work to our benefit. As I talked about last year, most of the things that drive our economy bring dollars from the rest of the world into this community. They're not dollars that are generated from here. They're money that comes, you know, the Medicare comes from the federal government, Medicaid comes from the state government, agriculture we sell overseas and the money comes here. Wine we sell out of state. We're certainly not drinking all of it here. And healthcare brings dollars from outside our communities. Even as Kadlec becomes more regional, we're bringing dollars from the region into the Tri-Cities. All those things will help mitigate and help our future economically. Last couple slides. Kadlec is an economic driver. That's a pretty busy slide. Each of those dots is 1 month from the year 2000 through the end of 2011, and its admissions. We were between 500 and 600 admissions a month back in 2000, and today we're running between 11 and 1,200 admissions per month. Now, that's obviously not just growth of the Tri-Cities. We're not 250% bigger now than we were 10 years ago. A lot of that's because we keep business here that used to leave town, and we bring people from other places here. But healthcare is going to be an economic driver. I don't have Tri-Cities information. I just use Kadlec, but you can see how healthcare is driving the economy. And this one is our payroll. Our payroll has gone from $37 million in 2000 to $130 million last year. And I don't see it slowing down as much as it probably needs to. So healthcare is going to be a major driver. If you're in healthcare, God bless you, it's going to be a tough decade. And if you're not in healthcare, you can count on those of us in healthcare continuing to spend a lot of dollars in the local economy. Yeah, we're going to struggle as providers. Employers are going to struggle with the cost of health insurance. Consumers are going to struggle because they're going to have to pay more of that. But healthcare spending is going to continue to increase in the Tri-Cities. Thanks. And hopefully I'm not